and just want to introduce myself. My name is Donna Klassen. I'm the co-founder of Let's Talk Menopause, a national nonprofit invested in changing the conversation around menopause so women get the information they need and the healthcare they deserved. I'm joined today by Jessica Levin, who is the director of Menopause Talks. Just want to start with a brief thank you to our panelists today. We also want to thank Revel, who is our partner in this, and also Alloy for supporting the Menopause Talks so that these can happen. A quick note, these Menopause Talks are for informational purposes only and not a substitute for menopause care or treatment or diagnosis. So just want everyone to be aware of that, especially during the Q&A. A few housekeeping items. We have the chat disabled, so if you have questions, you can ask them in the Q&A, and our panelists are going to answer them at the end. We will also give you some information and links in the chat, not the Q&A, so check your chat to be able to click on those links and save them. There'll also be a very brief survey at the end of the webinar, so we hope that you stay on so that we can get some feedback so that we can make these Menopause Talks better for you. So we are thrilled to be joined by Dr. Jewel Kling of the Mayo Clinic and Dr. Paru David, also of the Mayo Clinic. And we've decided that they are going to introduce themselves. So take it away.
Fantastic. Donna, thank you so much, both to you and Jessica for inviting us. But I think more importantly for the work that you're doing to really demystify menopause and create a space where women can get information about something that impacts all of us women if we live, to the age of 50, 51, and are impacted by symptoms. We're so excited to join you. As you heard, my name is Dr. Jewel Kling. I'm a women's health internist and the chair of our Division of Women's Health Internal Medicine at Mayo Clinic in Arizona, and really have the joy and pleasure of every day working with Dr. Paru David, who I'll let introduce herself.
Thank you. I'm Dr. Paru David, and I am also a women's health internist here at Mayo Clinic in Arizona. And I've been taking care of menopausal women for over 20 years. And so we're really excited today to bring you the latest guidelines from the North American Menopause Society. But before we get into that, Jewel, can you tell us a little bit about NAMS?
Yeah. NAMS is a fantastic organization that I think many of us that are working in this space are affiliated with, either attending their conferences or reading their journals, or like what we're doing today, thoroughly reviewing their position statements to find out how it informs our clinical practice. The North American Menopause Society is the leading nonprofit organization dedicated to promoting the health and equity of the health and quality of life, rather, of all women during midlife and beyond through an understanding of menopause and healthy aging. I think one of the things that NAMS does really nicely is recognizes that there's some benefit to us really understanding this information well, and demonstrating that we know that by certification. So NAMS has a certification called the North American Certified Menopause Practitioner, the NCMP, which you'll see at the end of our names if you ever get emails from us or on other advertisements or things like that. But to be a menopause practitioner through NAMS, you have to go through training, read through a book usually, and take a test, and then continue to get continuing medical education in menopause.
Thank you for that explanation. And so, that kind of takes me to, well, what are these guidelines? And so the North American Menopause Society, or NAMS, they put together these position statements where experts in the field of medicine, of menopause, get together and review the medical literature out there, all of the research that's available regarding hormone therapy, and then they make guidelines for us as clinicians. And this helps us when we counsel our patients regarding hormone therapy. And we want to bring this information to you about the latest guidelines that was actually published earlier this year. So to begin this conversation, Jewel, tell us what is the main message that we're trying to give clinicians regarding hormones for menopause?
Yeah, I think this is the important point. So for those of you that are joining, if for some reason you have to step out or whatnot, I hope that this is the message you take away, that our understanding of the safety of hormone therapy is much better now than it has been in the past. And the position statement really reaffirms that, that we know for women less than age 60 or within 10 years from their last menstrual cycle, that if they're having symptoms, hot flashes and night sweats, that typically the benefits of hormone therapy are going to outweigh the risks. And for symptomatic women, they can consider, have a discussion with their clinician about the role of hormone therapy. An important part of that is that hormone therapy is still the most effective treatment for the hot flashes and night sweats associated for menopause. So part of like everything we do in menopause, we want to use the most effective tools to treat our patients, and that's hormone therapy in this case.
Right. And, the other thing is that, this improves quality of life. When these patients have relief of their hot flashes, night sweats, it not only does that, but it also improves their sleep. And so naturally, their quality of life improves. However, there are some contraindications to hormone therapy. And so, that's why we do a benefit risk analysis on our patients. The current contraindications include history of stroke, history of a heart attack or breast cancer, or even blood clots. Let's talk a little bit more about the duration of hormone therapy. I think that, we heard really nicely from Jewel that, we have this window of opportunity to start hormones for patients. But the next question that always comes up to me is, well, how long can I continue these hormones? And I think that that's what's really nice about these new guidelines, is that there is no upper age limit now for the continuation of hormone therapy. Previously, we used to tell patients that, look, at age 60, we really need to talk about really decreasing the hormones and then eventually stopping. But there's been some really good information saying that, hey, if this is working for patients, let's continue hormone therapy, especially if it's helping their hot flashes and night sweats.
Yeah, now I'm so glad you bring it up, because I think every patient I see for a menopause consult asks me, hey, Dr. Kling, first of all, how long is this going to last? Which I think acknowledges that it's, for most women, they're really significant symptoms that are really crummy. And for so long, I think, women heard or thought that they just had to tough it out. But when we share with them that for a majority of women, the average duration of symptoms are anywhere from 7 to 10 years. And that's not shared to discourage women or be disappointing, like, holy smokes, I have to have these symptoms for that amount of time, but really to validate the importance of us having a discussion about treatment of symptoms. So if a woman is typically around 50, 51 when she goes through menopause, and she has an average duration of symptoms for 7, 10 years, that means many women will continue to have symptoms up until 60. But even as you've shown in your research, Paru, women beyond 60 continue to have hot flashes and night sweats. And so instead of what maybe we've done in the past, where, okay, you're getting to be 60, we know risks of heart attack and stroke go up, let's stop you on your hormone therapy. Instead, the conversation can change to say, hey, you're getting into your 60s. We know those risks are going up. Let's see if we could get you off of hormone therapy. But if not, like if you stop your hormone therapy or you taper down and your symptoms return and are significant and are impacting your quality of life, then the benefit of continuing hormone therapy makes sense. Now, clearly, if there's something that changes, right? So if a woman gets breast cancer or has a heart attack or a blood clot, then it warrants that discussion. And it may mean that they're switching to a non-hormonal option to manage their vasomotor symptoms. But for healthy women that are, taking good care of themselves, implementing this healthy lifestyle, I think this is really reassuring.
Yeah, absolutely. And one of the other things that I talk about with my patients, as they, are over the age of 60 and are still having some hot flashes and night sweats, I tell them, well, why don't we try to decrease the dose but yet manage your symptoms? And so by decreasing the dose, we can still reduce their risk.
Yeah. And the other thing, and I may have even learned this from you, Paru, is the type of hormone, like the formulation, how they're getting hormones, whether it's oral or through their skin. Does that make a difference? Like, will you talk about that with patients as they get to age 60?
Yeah, absolutely. So, one of the things that we now know is that there is a difference whether you take it orally or transdermally. So transdermally just means that it goes through your skin. And one of the most common ways in which we deliver this transdermally is through an estrogen patch. And so when, we talk about, well, what are the differences? What are the benefits? When you take estrogen orally or by mouth, it has to be broken down or metabolized by the liver, which can increase some of your coagulation factors and therefore increase your risk of stroke. So when you use an estrogen patch, it goes directly into the bloodstream, therefore bypassing the liver. And it can, and the studies have shown that it possibly can reduce the risk of developing a stroke.
Yeah, certainly associated with a lower risk. So if you're not getting those, clotting factors, if it's getting processed through the liver, then less risk associated with that, which is really reassuring, I think, to us as clinicians, but also to our patients, right? That read, those of you that are listening that either have heard of people that have had clots related to estrogen or whatnot, that there's this difference, especially when we're talking about estrogen in a menopausal hormone therapy formulation, if it's through the skin, which is great. And maybe, I don't know if we've talked about this yet, Paru, but while we're talking about formulations of hormone therapy, one of the important things that I think we try and share with our patients is when they need a progestogen or not. So maybe you can talk about that a little bit more.
Yeah, absolutely. So, we've talked a lot about estrogen, and estrogen really does help the symptoms of menopause. But when do you use a progestin or progestogen? So that's either a synthetic progesterone or a natural progesterone. And so we usually use that if a patient has not had a hysterectomy and still has their uterus intact. Because if we use estrogen alone in those women, it can increase their risk of uterine cancer. So when we add the progesterone or the progestogen on board, then it significantly reduces that risk. And so that is a definite indication for using a progestogen.
And that's one of the things, at least when I was looking at the position statement, that there is certainly more detail recognizing that, the type of hormones that we're using, how women are using them, are they orally, are they transdermally, and if you need a progestogen or not, oftentimes influences some of those outcomes. Including things like breast cancer, which I know we'll talk about in a little bit more detail. But one of the things that I know initially when I started learning this information, but I hear from patients too, is what is the difference between what you're talking about, the estrogen patch, the estrogen pill, and the progesterone versus like a low dose vaginal estrogen? And when we're talking about risks and benefits, duration of treatment, like therapy, like is that the same for a low dose vaginal estrogen as it is for, I think, what we'd call a systemic hormone therapy?
Right. There are differences. So we kind of divide it up into systemic hormone therapy or systemic estrogen, which, is all throughout our body, and then local estrogen therapy. So what we do know is that many women develop vaginal symptoms after menopause. And many times it takes years for this to develop. And what happens is the vaginal tissues ultimately become depleted of estrogen. And there's a lot of symptoms. I think before we used to say, oh, it's just vaginal dryness or atrophic vaginitis. But really, we've now come to understand that it encompasses much more than that. And in fact, the new terminology is called genitourinary syndrome of menopause, because not only is it the vaginal dryness due to the lack of estrogen, but it's also urinary symptoms as well as painful sex. And so what we can use is local low dose vaginal estrogen, which can really help these patients. The other thing is that, for the systemic estrogen therapy or hormone therapy, we talk about this window of opportunity. But for local therapy, we can start that at any time, and you can use it indefinitely, especially if it is helping our patients.
That's such an important point. I think so reassuring to patients that or women that notice benefit from low dose vaginal estrogen, that they know they can start it when they need it and they can continue it indefinitely. And maybe an important point to highlight why that is because low dose vaginal estrogen mostly works locally. It works within the vulvar and the vaginal tissue, so it doesn't get absorbed to cause those systemic risks like, what we're talking about here, heart attack, blood clot, those type of things. Now, one of the things that's important for us to highlight, which I always make sure to emphasize to my patients, is that there are those differences. However, how the FDA labels the packaging is they just do a class effect. So if they pick up their vaginal estrogen, their low dose vaginal estrogen, it may have a black box warning that says this is going to cause breast cancer, blood clot, heart attack, and stroke. But we know that's not the case. We have plenty of research that supports that this low dose vaginal estrogen indeed does not have those same risks as systemic therapy. And so I hope, those that are listening know that and know that they can continue it, because it does not only treat those symptoms, which by themselves are enough, but those symptoms greatly impact quality of life. And this becomes a quality of life factor for women. If you're having recurrent urinary tract infections, pain with intercourse, these are part of health and really need addressing long term.
Absolutely. And I'm so glad that you brought that up, because it's so true. I think many women just kind of say, I'm just going to live with it or deal with it. And it certainly can improve a woman's quality of life. And I, definitely, ask all of my patients about vaginal symptoms, because sometimes patients are shy to bring that up. So when I'm taking care of women, taking care of them as a whole, we want to discuss not only the systemic symptoms like the vasomotor symptoms, but we also want to talk about vaginal symptoms as well. One important caveat that I want to point out is that it is local estrogen therapy. So these are patients that don't need to use any progesterone therapy if they still have an intact uterus, because the amount of estrogen that is being absorbed is very, very low.
That's a really good point. Thank you for highlighting that. And I guess in this same vein, we're talking about kind of misconceptions, women thinking that, this is a symptom I just have to deal with, or, because, prior to more recent and prior to opportunities like Let's Talk Menopause, women haven't talked about these kind of symptoms. They may think that pain with intercourse is just a natural part of life, which is not the case. Dr. David and I here to share that news. We don't want you to have pain with intercourse, and there are things that we can do. But other myths or other misconceptions or fears that maybe just aren't warranted by the data that I hear a lot are related to breast cancer risk. And I'm hoping we can talk about that a little bit. Paru, are you hearing that too? Do patients bring that up with you?
Oh yeah, absolutely. Patients are worried about this risk of developing breast cancer. And I think that we really need to put it into perspective for patients. If you have a patient who is on combined hormone therapy, estrogen plus a progestogen, the risk is really 1 in 1,000 yearly, or 9 in 10,000 patients who are on these hormones yearly. And so, that risk is low, and these are average risk patients, and so I think that those numbers are really helpful for patients. But the other piece that I, tell patients is that we need to put this into perspective. There are so many things that we do on a daily basis that increase our risk for breast cancer, and these are things that we can do something about. So, many patients don't realize that drinking 2 glasses of wine per night or 2 alcoholic beverages per night can increase your risk, not exercising enough, or, being overweight. And these are things that we can really, change in our lives that can reduce our risk.
Yeah. And such important things for us to focus on at midlife, when our risk of things like heart attack and stroke start to go up. So you get that twofer, right? Like you're focusing on healthy habits, exercising regularly, monitoring your diet to help reduce that risk, but also those things reduce your risk of breast cancer, which is so important. And I think what's challenging about this discussion is we certainly don't want to minimize the fear of breast cancer, or maybe not the fear, minimize the need for us to be discussing breast cancer, because all of us women, because we have breasts, have a risk for breast cancer. But I think at least my goal in this discussion is to make sure that women do put that into perspective, so they're not discounting or not choosing to use a quality of life impacting treatment that has so many benefits because of a fear that is considered rare, especially for those women, like you were saying, Paru, that are average risk. And so it would be acceptable to consider hormone therapy, and just to round this out a little bit, the other thing, which I think is really interesting and has been highlighted in this position statement, when comparing it to past, is that we know better now that the risk of breast cancer also depends on what type of hormone therapy you're using, meaning if you need just an estrogen because you've had a hysterectomy, it doesn't look like that estrogen may significantly impact your risk of breast cancer. Again, remembering that all of us women have a risk of breast cancer, so your risk is not zero, but it's likely not going to be influenced by using estrogen. However, it's those women that are on both an estrogen and a progestogen that likely have the slightly higher risk. And it tends to be related to duration of use. So after about 5 years of use. So for some women, they may choose to, use it for a shorter period of time. But I think just really reinforcing that low risk. Continuing screening, mammogram is important, being aware of those things, but use a treatment if it makes sense for you.
Right, right. And I think that also brings up the point that, it is worth reviewing it with reviewing all of this with patients on a regular basis, meaning at least on a yearly basis, to talk about, well, hey, does this still make sense? Us continuing hormones? I mean, let's look at the big picture. Let's look at everything, breast health, your heart health, your overall health. And are you still having symptoms? And so that's how I, manage it with patients. But, since, we're talking about the whole patient, what about bone health?
Yeah, bone health is a great subject to talk about. It's so relevant for postmenopausal women. And maybe before I talk about that, I'll just say something real quick, Paru, because for those women that are attending that maybe have a history of breast cancer, I just want to make sure we include that, disclaimer that we still do not recommend hormone therapy for women that have had breast cancer or have breast cancer right now. But with that said, I hope that doesn't come across as, no, you don't get treatment for your menopausal symptoms. Thankfully, we have plenty of evidence-based treatments to help with hot flashes and night sweats or other symptoms related to menopause for women that have that contraindication of breast cancer.
That's so good that you mentioned that. I mean, when I see my patients for menopause, I just want them to know that there's a lot of good news with menopause. I think that sometimes patients feel, that there's all these changes happening with their bodies, but just like you said, there are so many treatment options, not just hormones, but really good options for our patients.
Absolutely. And talking about options, one of the considerations when we're looking at that benefit risk ratio for hormone therapy is looking at bone health. And I believe you said this at the beginning, Paru, the two main indications for hormone therapy is for treatment of hot flashes and night sweats. Because again, we know estrogen is the most effective treatment for treatment of hot flashes and night sweats, also called vasomotor symptoms. But it's also indicated for the prevention of osteoporosis. So when we're seeing women that are having symptoms and they're trying to decide, does this make sense for me? If they have risk factors that would put them at higher risk for osteoporosis, for example, past long-term steroid use, or, family history of osteoporosis, their mom, their maternal grandmother had osteoporosis with fractures, those type of things, this may go into that category of a pro. Why to be on the hormone therapy is to prevent osteoporosis. Now, a lot of my patients will ask, especially even older women, we're talking about older women in menopause. Well, would hormone therapy be something we can use to treat osteoporosis? And Paru, I'd love to send that question to you. What do you tell your patients, and maybe what does the position statement say about that?
Right. So I think that's an important distinction, is that although the risk for bone loss increases in menopausal women because of that loss of estrogen, that actually hormone therapy is not indicated for the treatment of osteoporosis. And that the reason for that is that we have really good medications that really target bone, improving bone density. And so, we don't have to rely on hormone therapy. Now, if you have a patient that needs hormone therapy for vasomotor symptoms, then obviously we can use it for that. But just for the indication of osteoporosis, it is not being recommended for that.
Thank you for that. Yeah, no, that's good to know. And I guess just shifting gears a little bit here, talking about another, important population of women that is highlighted again in this position statement is women that go through menopause early or really prematurely. So early would be less than 45, prematurely before 40. Are you seeing those women or recommending those women take the bone medications for their osteoporosis or to prevent osteoporosis, or would hormone therapy be a good thing for them for prevention as well?
So they're a unique group of women. So they've gone through menopause early or prematurely, and so they will benefit by going on hormone therapy to keep their bones strong, in addition to many other factors that improve their quality of health, including cognition and things like that. So, definitely for those women, I think it's really important that we put these women on hormone therapy and continue it at least until the age of when they would have gone through menopause naturally.
Excellent. So it's favored to use hormone therapy or even maybe, contraceptive pills like birth control pills for women that go through premature menopause to support their bone health. But you bring up a really good point. We're talking a lot about symptoms, and absolutely for women going through menopause between 51 or a little bit older, we're focused on using hormone therapy to treat symptoms. But for women that go through menopause prematurely, the role of hormone therapy is bigger. Really, the goal is to help prevent the long-term health consequences. We see women that go through menopause prematurely have higher risks or rates of things like Parkinsonism, dementia, sexual dysfunction, osteoporosis, these type of things. And so thankfully, hormone therapy can mitigate those risks. And so women need to continue on that at least until the average age of menopause, which is around 51. And it's not just to treat symptoms. And so they may come into your office without symptoms, right? Pari, you've seen that, right? Like a woman that had maybe a hysterectomy for endometriosis in her early 30s and is not having symptoms, but there's still a role in this case to be on hormone replacement therapy to help prevent those long-term health consequences.
Right. Especially if they've had their ovaries removed and you determine that they've, lost their estrogen. Absolutely. But, a question that comes up all the time for me is that, well, what happens when I get to the average age of menopause, about 50, 51, 52? Do I continue hormones? Do I have to stop because I had hormones for so many years? And actually what I tell them is that, hey, now I'm going to put you in how I treat all my other patients who are now menopausal. We continue hormone therapy for the treatment of vasomotor symptoms and for the prevention of bone loss. So, if it makes sense, I do continue these patients on hormone therapy.
Excellent. Just thinking about other questions that our patients have when they come into the office or that I hear from other clinicians. If, for example, in that case, that patient that comes to see you in her 50s and actually wants to stop hormone therapy, how do you usually navigate that? Like, do you have women just cold turkey stop it, or do you have them taper off of their hormone therapy?
I generally have patients taper off. I think that, you will be in much better favor with them if you have them taper. And so what it does is we're decreasing the dose very gradually. And sometimes patients will say, oh, when I drop down to the lower dosage, I could feel some breakthrough hot flashes. And so that is an indication to me that we may have to continue hormones for a little bit longer, especially to help your quality of life. And so that has been my traditional way of kind of helping with those patients.
Yeah, well said. Now, and I think the literature would say either way, really, at least in the data, looks similar, but similarly, kind of anecdotally, women do better if you can taper, and they can have some control over how to reduce down on those estrogen products.
Right.
Excellent. Well, I see that Jessica has jumped on. I wonder if we have some questions here from our audience members.
Yes, we have. We actually have amazing questions. I want to first thank you both. Just that introduction was so much more thorough and illuminating than I'm sure the vast majority of people get from their doctors. And so I just wanted to share some questions now with you. I'm to start with just a very simple question someone asked is when you're talking about premature ovarian insufficiency, what do you consider premature? So at what point do they fall back in the category of women who then you put into the normal age bucket?
So there is some terminology revolving that traditionally, if they're younger than 45, it's considered early menopause, but if it's before age 40, it's considered premature ovarian insufficiency. It's more terminology, but I think the treatment is the same for these patients, and just that identification of women who no longer make estrogen or have had their ovaries removed. But I think it just needs to be high in, on our minds that, look, these women are going to be at risk if we don't replenish their estrogen.
One other thing I'd love to add to that, if there's people that are joining that maybe fit in those categories, is the other distinction that the age category highlights is really the need to just evaluate it and work it up a little bit more. So for women that go through menopause before 40, not because of a surgery, so what we'd call premature or primary ovarian insufficiency, it's beneficial for them to talk to their clinician about blood tests or other evaluations to determine why they may have gone through that, as well as discuss, treatment, including hormone therapy.
Also looking at women who are going through perimenopause. So they haven't gone through menopause yet. Someone asked, can they take hormones even before going through menopause if they have difficult symptoms they're dealing with?
So that's a great question. So we know that about 10 years before the onset of menopause, women will begin to have minor fluctuations in their estrogen levels, which can lead to perimenopausal symptoms. Initially, it may be very mild. I have many patients who will tell me that, maybe I can't sleep as well, or maybe I'm just a little bit more moody. Or sometimes patients will say just PMS feels a little bit worse. And then as they move forward, closer to late perimenopause, that's when all of the period changes occur. Heavier, lighter, longer, shorter, closer together and further apart. And so, yes, many of these women, especially when they're having those period changes, they have enough highs and lows in estrogen that precipitate these vasomotor symptoms. And so I tell patients that, yes, absolutely, we can treat you. However, I think it requires a close discussion with the patient to kind of find out where they are in this transition. Because if they are earlier in the transition and we give them hormone therapy, which is a fraction of what they're making or what's in low dose birth control pills, they may not be able to feel it. They won't notice a change. Instead, what I do for these patients is that I tell them, by going on low dose birth control pills, so that means a 20 microgram dose of ethinyl estradiol in their birth control pill. And if they take it in an extended cycle fashion, so that means, taking it continuously for 12 weeks and then, taking a break from the pills, that actually has been shown to really help control perimenopausal symptoms.
And the other benefit is it provides a contraceptive option, right? I think many of us, as we get into our mid to late 40s, we just assume I'm not going to get pregnant, right? That's not going to happen to me, which in fact, you can get pregnant up until 12 months past your last menstrual cycle. Like, you're technically able to do so. While the risk may be low, we still need women to be aware of that, because I can see Paru shaking her head, because I know all of us have had patients in our practice that in their late 40s, get pregnant without intending to do. And some women maybe are trying to, and that's great, if you're doing so, but it puts your body at higher risk being older and getting pregnant, and many women are not interested. And so having a tool that treats their perimenopausal symptoms but also provides contraception can be helpful.
Exactly. And that's patient education that I do. Many of us are aware of the higher rate of unplanned pregnancy in a woman's teens, but there's a bimodal distribution of unplanned pregnancies. And so the first spike is in a woman's, teens or early 20s. And then the second spike happens in a woman's 40s, simply because she feels, oh, I won't be able to, I may not get pregnant. So that's such an important point.
Another set of questions, and we get these a lot, is around synthetic, natural, progesterone and estrogen. What are the differences? Bioidentical, it's very confusing for people.
Yeah, go ahead. Joel.
Yeah, no, I'm so glad this came up, and it comes up on a daily basis in our clinic and our practice. Bioidentical is a term, really just a marketing term. It means that the hormone looks like the same hormone your body makes. So in this case, estradiol, or 17-beta estradiol, is what our ovaries make. Progesterone is what our ovaries make. And so we can use bioidentical products. After the Women's Health Initiative, which was a big study back in the 1990s that closed early, in early 2002, that identified risks, many practitioners stopped prescribing hormone therapy. Many women stopped using it, and that led to this need. And that need was filled by really custom compounding bioidentical hormone prescribers, claiming that because it's custom compounded or bioidentical, that it's safer than what we would prescribe. But the reality is it's not safer. We actually have very little data to know about the safety profile of custom compounding. And there was a recent national science review that looked at this and said, hey, we have plenty of wonderful FDA approved products, including FDA approved bioidentical products that we know are safe and we know are consistent. So we should be using those treatments and not custom compounded treatments. And so that's typically what we're recommending to patients, is that we can prescribe you an FDA approved bioidentical patch of estrogen or progesterone. When we look at that compared to some of the other formulations, like maybe women have heard of conjugated equine estrogen or Premarin, we do see some benefits in using these bioidenticals. There is an improved safety profile. But again, really the conclusion there is an FDA-approved bioidentical product is going to be safer and better for women than a custom compounded product.
Yeah, no, I think that those are great points. Many patients are not even aware, that that there are FDA-approved bioidentical hormones with estradiol or progesterone. And so when I have this discussion with them, they tell me, wow, I never realized that. And, we make the transition over.
One thing you mentioned, Dr. Kling, about progesterone patch versus pill, someone asked that question. So I'm hoping you can clarify that.
Yeah, so the estrogens, the estradiol, can be either in a patch, there's a pill, there's a spray, there's a vaginal ring, and there's a gel. The progesterone, though, needs to be oral. So that's going to be in a pill formulation. We haven't seen that progesterone delivered in other ways, like through a cream or, through the skin, is sufficient enough to protect the lining of the uterus when we're giving an estrogen. And so if women are on hormone therapy with an estrogen, they need to take an oral progesterone to protect the lining of the uterus.
And just related to that, we got a question about how you determine dosage, and to what extent does the dose of estrogen affect the dose you need to give a progesterone?
You want to talk about that, Paru?
So yeah, I mean, usually as far as when I pick an estrogen dose, I like to, my go-to is an estrogen patch because of the benefits that we talked about earlier about the transdermal route. And, when I have a patient who is brand new to, starting hormone therapy, I usually just start middle of the road. And that is equivalent to, say, 1 milligram of oral estradiol, and it's 0.05 milligram patch. That is the dose I tend to go to. And then depending on their symptoms, I either go up or down on the dose of the estrogen patch. When I match a progesterone, and most patients want to do the natural progesterone, which is Prometrium, I usually go with 100 milligrams. It comes in both 100 milligrams and 200 milligrams, but I typically go with the 100 milligrams. And most women do not want to have a withdrawal period, so they do like to take it every day. So that would be considered continuous combined hormone therapy.
Yeah, and the 100 milligrams is the dose that's recommended for endometrial protection.
Mm-hmm.
So can I say one other thing, Jessica? Is that okay? I see you have another question there. One of the questions that comes up a lot that I hear from women too is, well, Dr. Kling, won't you check my hormone levels and individualize the dose to my hormone levels? And, at some point in the past, we may have done that, but what we've found is that those hormone levels don't always associate with symptoms. So you could check it and it could be high, but if you're having symptoms, you're still going to adjust the dose and vice versa. And so it's so much more precise to individualize our treatment to a woman's symptoms. And so just like Dr. David said, we choose a dose, we monitor them closely. If they're not noticing improvement, we can increase the dose. If they're noticing symptoms from the estrogen, we can reduce the dose and individualize it that way as opposed to checking hormone levels.
A number of people, because the most in the guidelines, and you guys also mentioned, the most common prescription of hormone therapy is for hot flashes and night sweats. A number of people have mentioned other symptoms. Someone spoke about the hormones helping with their mood regulation and energy, helping them sleep more. 2 people asked about weight and helping them with weight. How do you think about, the prescription of hormones for what people commonly think about and all these other types of symptoms, whether the hormones help, how much, how you make your decisions about that?
Yeah, so you mentioned quite a few symptoms, so for mood, I have a lot of patients that will come in with mood instability, and actually whether it's, irritability, increased anxiety or depression, and, there isn't an indication for starting hormone therapy for that in a postmenopausal women. But what I found was interesting is that in perimenopausal women, the hormones actually can help. And so, I do use it, for that if a patient is coming in with some of those symptoms, in addition to some of the other things of perimenopause, it can sometimes help their mood as well.
And that's consistent. There was a guideline about the mood changes during menopause that came out about 3 or 4 years ago. And usually our main go-to for mood symptoms are what we would use at any stage of life. So, cognitive behavioral therapy, sometimes antidepressant treatments. But it does appear there's some literature that suggests that in that perimenopausal, especially that late perimenopause, that hormone therapy or hormones may be beneficial at stabilizing mood. But just like Dr. David said, postmenopausally later in menopause, hormone therapy is not going to be the main go-to for mood. Although, and I so sorry if I interrupted you, Paru, but many of the other symptoms that we're talking about, and we keep mentioning hot flashes and night sweats because that's the main FDA-approved indication for hormone therapy, but certainly not to discredit all those other symptoms that women are feeling, because there are a lot of different symptoms that can occur at menopause. Some may be related to the hot flashes and night sweats, and some's not, some just related to the changes that are going on in your body. But if it's symptoms symptoms like sleep, vaginal dryness, cognitive fog, joint pain, and muscle ache, all of those symptoms, while hormone therapy is not indicated specifically to treat those symptoms, oftentimes when women have improvement in their hot flashes and night sweats, that then leads to improvement in sleep. And improvement in sleep can lead to improvement in cognition and improvement in mood and improvement in hot, joint pain symptoms and things like that. So I guess we want to make sure that what listeners are hearing is that while it may be, the door may be open to talk about the hot flashes and night sweats, often those quality of life improvement is because it helps with all those other symptoms typically too.
A big question that I get all the time is, if I go on hormones, is that going to make me gain weight? And, overall, the studies have shown that there isn't a significant amount of weight gain with the dose of hormones that we're giving patients. So I think that that's really important to understand, because there's so much more that's happening around menopause that may be independent of hormones, that can be contributing to the change in weight that's occurring at that time.
I want to go back to just a few contraindications, because I think it helps everybody just to know about that as they're making their decisions. You said for women who have experienced breast cancer that hormones are not, you don't prescribe hormones for that group generally. There are many women who haven't had breast cancer, but who have a family history of breast cancer. How do you think of those women in relation to systemic hormones and local therapy?
This is such a great question, and thank you for asking it. And maybe, the important point here is making sure anybody that's listening knows that have that discussion with your clinician about your breast cancer risk. There's lots of things that can influence that risk. Family history is one of those. Other factors about our life, like when we had our period, if we've had breast biopsies, those type of things can also influence that risk. And if you are indeed found to be at elevated risk, which we use tools to calculate your lifetime risk, and if that's above 20%, then that discussion about the role of hormone therapy may be a little bit more nuanced. And for women in that case, oftentimes we're recommending treatment to block their hormones. There's medications that reduce risk like tamoxifen and the aromatase inhibitors, and so it wouldn't make sense to use hormone therapy for them. But if they're having, menopausal symptoms, it may be offering non-hormonal options, either medications or therapies like cognitive behavioral therapy or clinical hypnosis, which are evidence-based treatments that can help with the symptoms of menopause. And then those high-risk women are going to be doing increased surveillance for breast cancer, so annual mammogram alternating usually with a breast MRI as well. Taking the opportunity to explore if genetic testing makes sense too, to see if perhaps they have one of the genes that puts them at higher risk, which may have some implications for different screening or other treatment options too.
So I have one final question for both of you. If someone comes in and either decides they don't want to take hormones or can't take them based on your collective judgment, you said there are a number of other strategies you discuss with them, and I'm wondering if you could talk a little about that.
So after doing the benefit risk analysis with the patient, and then definitely taking into consideration patient preferences, because there are patients who still, after the discussion, may not want to take hormones. And so then that's when we talk about non-hormonal options. And I break it up into a couple of different categories. And in fact, the North American Menopause Society does have nice guidelines on that as well. They have a position statement for that. But, by and large, we break it up into prescription therapies. So these are mostly going to be some of the antidepressants, because the SSRIs or SNRIs, and they have been shown to independently help with hot flashes, and in addition to helping with mood. And so I do have some patients who have both. They're having vasomotor symptoms and they're also having mood disturbances. And, we talk about all the various options and they tell me, oh yeah, that sounds really good for me, because for me, it's not so much the hot flashes, but really it's the mood that's really bothering me. So that's one kind of big category. There's also some supplements that are available. And then there's a couple of, integrative options, including cognitive behavioral therapy and hypnosis, which were both found to be beneficial in helping vasomotor symptoms. Jewel, do you have some other things that you discuss with patients?
Yeah, well, no, that was really well done. And I was just going to say, stay tuned. NAMS is updating their position statement on non-hormonal options this year, so that should come out. The only FDA-approved treatment is paroxetine, which is one of the selective serotonin reuptake inhibitors, or SSRIs. And I think the good news about all of those medications is that we see that lower doses treat symptoms. And why that's a good news is because side effects from those medications are dose dependent. So the lower dose tends to have less symptoms. And the symptoms that women oftentimes, when I bring that up, that they'll like, no, Dr. Kling, I don't want any sexual side effects or weight gain, because they may have heard that those medications can cause those. The good news is in a study looking at that lower dose of paroxetine, the 7.5 milligrams, that we didn't see it influenced sexual functioning or weight compared to placebo. And I'll just say one other point here is I think many of us women are sensitive to this idea that we go to see our doctor and we share a symptom and they're like, oh, here's an antidepressant to treat your symptom. This indication, when we're using these medications to treat menopausal symptoms, it's not implying that these symptoms are in your head, or it's not, necessarily even related to mood. They're menopausal symptoms. Your body's going through a huge change. We just happen to find that the same neurochemicals that we use are improved to treat depression and anxiety also help with hot flashes and night sweats. So I share that because I just don't want women to avoid using those because of that perception or social stigma or whatnot. Like, there's tools here to help you and you don't have to tough it out.
So you mentioned, I think we have time for one or two more questions, and then Donna's going to pop up. And you mentioned you had some questions for each other too. Are there any we haven't gotten to that you'd like to ask each other?
This group of listeners is fantastic. I think they covered all of the things that we thought, hey, if we didn't get to, we should ask each other.
Yeah.
Great.
This has been, am I on? Yes, let me just see this.
Yeah.
This is amazing, I have to say, that this has been one of the most informative and wonderful menopause talks. And I think that our listeners really benefited from it. And I think the last part was really important, what you said, Dr. Kling, just that you don't have to suffer. There is treatment, and that you can feel better and that you deserve to feel better. And I know, speaking for myself, somebody who actually has breast cancer and is on an aromatase inhibitor and went into surgical menopause and then went on anastrozole, I had a ton of symptoms, and I was somebody who had no prior mental health history. And I am on an antidepressant, and it helps me tremendously. And again, I had no history of being on an antidepressant, and I'm open about it. So I really want people to know that I know there's such stigma, and I'm a therapist, right? So I work with women, and there is such a stigma around it. So I just want people to know that. And I think that was just super, super helpful.
Thank you so much for sharing that. That's so important. Yeah.
That's what I was going to say. It's so powerful to hear these stories. And I'm so glad that you found something that can help with the vasomotor symptoms.
Right. Well, actually, I just want to say that I know that there's some non-hormonal treatments coming down the pike. I know that Bayer and Astellas are making something, because we know now more about why we're actually having those vasomotor symptoms when we take and so do you know when those are going to be out?
No, not yet.
Okay.
Hopefully we'll find out some more next month at our NAMS meeting, but I think it's making good progress.
Right. So I just want to let people know that, and that the antidepressants, the low dose can help also with mood. So they can help with mood because irritability is a symptom, right, of perimenopause and menopause. And people don't recognize that often as a symptom. They just symptom. They often just think like, oh, I don't know what's wrong with me. Something's I'm not, or they say they're not themselves. And so again, irritability should not just be taken as like, something that we should accept, right? And one of the things about CBT, I guess I want to say, is that knowing that a lot of these things are symptoms can help. And so just labeling them as symptoms can sort of take it away. And I think that's just, helping people understand like what a therapist or what CBT can do. Okay, we're going to wrap up now. So thank you, everyone. Thank you to our guests. I'm going to put up a slide here in a moment, but just want to thank Dr. Peru David and Dr. Jewel Kling from the Mayo Clinic. You're fantastic, and what a benefit to our listeners. This is part of our monthly